to talk about the innovations within the framework of the series of webinars that we actually call innovative ones of primary care in health, that has been sponsored by the World Bank and Salud Derecho from the prior years. So I am Oscar Bernal. I am the facilitator group of the World Bank, professor of the Andes University. I please receive a very warm greeting of the people who accompany us from the different places of Colombia, Latin America, North America, Africa, and Asia, and Europe. This webinar also is going to be retransmitted directly through the channel of Salud Derecho. The session will be recorded for the purpose of academia, and it can be queried in the web ones and so on that have, then we have there of Salud Derecho. Prior to
el que también encontrarán información sobre eventos, publicaciones.
And then we have these events, the publications, and technical research. So we have here all the memoirs and all the recordings of all the webinars of all these series. In the chat, you will find there the bar, and then we have the microphones will be deactivated up until the first panel, and then we have to request the panel to be able to participate. And I invite you from now so that during the two panels that we have, you formulate your questions and comments through the options, questions and answer that you have in the lower bar or through the chat that you have in Zoom. We will have simultaneous translation in Spanish to English, English to Spanish. Firstly, I will hand over the mic to Pilar, who is a specialist, a senior specialist of the global practice of health of population, who will offer you a sort of status or snapshot of the whole series of Manuela. She's a doctorate in the sciences of Johns Hopkins University, and she has worked for more than a decade in issues associated with the financing of the health sector, health assurance, and quality of the service in countries of Latin America, Africa, and Asia. Welcome, Manuela. Thank you very much, Oscar, and good morning, good afternoon, good evening, depending to all. I wish to start by giving you a welcome to all participants that are here in Colombia and in the rest of the world. And then we have several participants that are very interested in Colombia. We also want to thank all the participants that have accompanied us during the last 11 webinars and all guest speakers who have showed us innovation ideas and many comments and contributions, and they have participated in many useful discussions to generate learning, and they have been fabulous in Colombia. I believe that it is also important to highlight that the ones who have been with us in the last 11 webinars have helped a lot of inspiration, and they have helped us so that we all think in different ways in areas of primary care and models of care associated to the primary care in Colombia. I would like also to take this opportunity to thank to this fabulous team that have led all these webinars and this learning opportunities and knowledge exchange. And I would like to start by thanking Maria Fernanda Oviedo, Juan Carlos Jimenez, Juliet Rodriguez, Oscar Bernal, Janet Bonillas, and Luis Gabriel Bernal. All, they have been truly the leaders of all this work, and they have brought to these conversations, and they have generated this enormous group of knowledge and of experts in the country. Just to comment, this community of practices and a series of webinars, they actually come after several years in which they have worked in research, in dialogues, in technical assistance, providing support to the Ministry of Health and in the country, and with whom we have consistently have found excellent examples of innovation and solutions to common challenges through the Colombian health system. but they have not been properly documented, they have not been properly disseminated or broadcasted. And in order to have a progress in the learnings of all these innovations in other contexts, we required a venue, a learning venue, an exchange venue. And the idea of these series was to create these venues to socialize, to document all the excellent experiences that we have throughout the country. And
Y creo que una de las cosas que nos dimos cuenta es que aunque hemos presentado más de 30
we have
innovaciones,
presented more than 30 innovations and more than 30 learnings.
apenas es una gotita en
It's
un
just
océano
a
enorme de
tiny drop
conocimiento y de
in the
innovaciones en
ocean
el país. Y
of innovations in the country. We did what we could, but there's plenty of room for exchange and to generate more knowledge. Of all these webinars, we have learned plenty about the innovations, and especially I think that it's important to point out that we have learned how we have implemented these innovations, not only the what, but how. I would like to highlight some of the key messages that I think are important to keep in mind within the next hour or next 2 hours of conversations of this webinar, of this uh, ending. And the first is that in Colombia, there are many things being done, many innovations in primary care, thanks or in spite of the regulation of the laws, thanks to the financing or the lack of it, or thanks to the problems or the lack of problems in health, or thanks to the social problems or lack of them locally and territorially. Also, I want to highlight that these innovations, this work that is being done in primary care throughout the entire country, is being worked, it's being taken to a progress in many aspects of primary care, that they actually include the availability and access of the first contact to the health system, that it includes the strengthening of the continuity of the care, that it includes the assurance, the existence of the health services, that it includes the strengthening of the coordination, that it includes the provision of services that are multi-sectorial, preventive, and curative, focused on the patient. And I believe that we all have our own definition of primary care. But I mean, it's important that we understand that all the progress, all the innovations are truly being taken to these key goals of a health system. And they are very, very important to keep in mind as goals, as vision. So for this, I want to stop there, but thank you very much. And Oscar, please. Thank you very much, Manuela. Next, we will have Luis Gabriel Bernal from the World Bank and the School of Medicine of the University of El Rosario, who will present a very brief summary of the most outstanding learnings and the key messages that we shared within the framework of these practices as a preamble of the panels that we will have here in continuity. Dr. Bernal is a specialist of family medicine and magisters in primary care, and he's designated by the Intersectorial Human Management there in the National Intersectorial Commission of Assurance of the Quality of Higher Education. He was the director of human talent in health in the Ministry of Health and Social Protection of Colombia, and he has been a consultant of PSI, of Results for Development, and of the World Bank for issues associated with health, primary healthcare in Colombia and Latin America and other regions. Luis Gabriel, welcome. Thank you very much, Oscar. Greetings to all present here. It is a pleasure to be here and write. I will try to be as brief as I can so I could I can give more time for the discussion. And I want to just share the main learnings, the key messages that generated of this community of practices about innovative models in primary care in Colombia that probably is going to nourish and be part of these discussions of the panels in the national level as well as the territorial levels in the provinces.
Webinars,
So, as you said, we had 11
eh,
webinars, as Manuela said. I am going to present to you those key elements that came out with those discussions with national international experts that they came about
que compartieron
from that knowledge of implementing them, that we shared experiences from different players in the health sector that actually provided these health services, insurers, the secretaries of health, of the educational sector, of universities, of the social sectors, of NGOs, and the like, all contributing to innovating primary care and not seen from a perspective not only of the first level of care, but rather seen from a broad perspective that is intersectorial, articulating of the different stakeholders that looks more like what we actually have within our framework of norms in Colombia according to the law that today we have in force, the current norms, the 1438 norm. So that first webinar of key innovative models of APS with which we started the series left a message that you saw on the left. You require differentiated care models in the territories and intersectorial look of health in order to achieve a true integral action. So in those
cómo
we
a
spoke
través
about the fragmentation of the system and how through efforts, if we actually see here, we have this set of norms that facilitate them and we could articulate them better of the system so that we can coordinate the actions from the primary care to provide the services and in the care in the different environments, not only in the service provision. We actually spoke about strengthening
comunidad
the primary care with the one near of the community that be easy of access, the health ones of community support around of where people live, and then to look at the attention, something more productive that is reactive, where you can find the people and you can characterize the population groups according to their risks, and at the same time to be able to take the services of promotion and prevention, of care, of rehabilitation, according to the needs, the particular needs of the people. And of course, this demands a great budget to make it more dynamic in that sense. In a
las innovaciones en
second
gobernanza
webinar, we spoke about the innovations in governance in the model of primary health care in the country, and we proposed a message that one should rethink a governance in health that is more representative of the national and local level. Colombia is a country that is quite heterogeneous, and we have a multiplicity of territories
diferentes
and conditions that differentiate the ones due to geography that actually demands a model that adjusts to the local needs, but at the same time, a strengthening of the territorial player, of the territorial stakeholder, a component of social participation and community participation that is very relevant with deployment and adjusting of the policies that enable one to adjust to the territory
sistema de atención primaria de acuerdo a
and a
las
reorganization of primary sector according to the population that they service. And likewise, the need once reiterates of the intersectorial ones using the conservation ones that already exist and a call to using the territorial ones that we have of health and the national social security ones. So these instances that already exist that enables us to come closer to the community, to understand better the ones and to respond better to their needs. We also spoke of innovation and financing of the models
tuvimos como referente de la comisión Lancet
of
sobre
primary models, and then we have as a reference the Lancet ones about financing the primary health care that we actually issued last year. And that one, we spoke there that the best should be free, it should be supported in public financing, and it should have mixed finances to promote efficiency and equity. And we know many a times the global costs of the health system, but when we go to discriminate those services from the service provision, which ones actually correspond to APSs to be able to cost them and to make them more dynamic, there we have an inconvenience. So we have a task, national and territorial, to establish those costs, and that way we can establish the arrangements with the key players or stakeholders, and then to find the financing that adjust themselves to the territory in materials of APS. Now we spoke of the need of a subsidy to the offer for the public hospitals as a premium payment per capita for the public hospital that allows one to take care of the needs, a network of public health services with economic difficulties, and that also one can understand and mobilize mechanisms that complement the financing when it talks about bringing the primary healthcare in dispersed or scattered areas. When it's difficult for the population to actually have it there, it's actually difficult to get to the houses in the territory. So we spoke about the payments and the incentives to the insurers should be associated to performance and discriminating those that actually do better than others and encourage those practices, or at least the current system that we have, and furthermore, to establish some premium payments associated with the risk of the population, the heterogeneous groups, and the groups that actually are receiving services from the local services of health. This should be recognized and it should be differentiated and paid. We spoke of negotiation scheme, payments, some incentives in the health, and that they're clear and regulated, and that also this becomes in a mechanism that assures quality. So you have these incentives in key norms and clear norms, and this actually can encourage quality. Also, we had a webinar associated with the models that were centered around community participations. We saw some very interesting ones with the ethnic component, intercultural component, where the message that they brought was in the measure that you involve the community, and especially when you talk about ethnic communities in the government, in the planning, in the design of the service provision, in the intercultural practices that one can exist. It was shown the experience of the hospital of Ambaloto Oribio in Cauca, how even in these knowledges, we managed to reduce them to zero and making use of the cultural practices, but also ensuring not negotiating really basic conditions of safety in order to prevent complications in pregnancy and in the delivery. So this was a model that was very interesting. We also saw some models of insurers in the Guajira province that are totally aligned to the beliefs and the values of the community. It answers to their needs, and they actually service their cultural and ethnic norms, but also the norms of health of the country. So it is possible to have this intercultural practice and still obey the law. And it was very active, that assures the timely response of the needs in health. We also had another debate about chronic illnesses and how to service them with innovation. And we spoke about the need to focus efforts in controlling the risk factors like hypertension, dyslipidemia. So habits like tobacco and alcohol, to reduce them so that we can reduce the prevalence of them, and therefore the expense that we will award to that one. And it's actually can grow like 3.5% annually in Latin America, according to some researchers. We also spoke about aligning the political will and the stakeholders in the different sectors so that they can service at different levels, the decisive factors so that you can invite everyone over and beyond the service provision in the working environment, the school environments, in the community, and with the use of telecommunication technology so that you can facilitate actions of all the different players and the monitoring in a timely way of these risk factors, as we actually said, in the environments of the community. We also spoke that also there is a potential risk, the chronic illnesses, and it also is a possibility to measure the improvement of quality and performance of these systems of primary care in respect of infectious disease and transmittable diseases. We spoke also about several elements that we actually can bring the diagnosis to the front of the patient at the beginning there, to the point of care test, very close to where the patient is in the domicile in this primary care, that enables them to make the diagnosis easier, then you can actually have this timely treatment, of course, mediated by proper training of the human resource in primary care so that they can actually take the test, that they don't necessarily have to be done by professionals. Once they could be technicians under professional supervision. And that they showed us with examples that were very interesting in Boyacá, for example, the Chagas disease, how they have reduced the complications associated with Chagas because now they detected and treated early. There's more knowledge of the health personnel trickle down, and then there's an effective communication of the risk amongst the people that enables people to sense it, makes them sensitive, and the people activate themselves in respect of the illness and they react, because many of the problems we said because the people didn't know the presence of this information because it was poorly diagnosed. We also spoke about the difficulty that the country has in terms of coverage of vaccines or immunization. So we have to be innovative in all these vaccination campaigns, that with adequate communication, we can demystify those inappropriate imaginary concepts of ill use of vaccine, but also an active search for the vaccine, not only waiting for them in the primary centers, but actually go to them to vaccinate. Also, we spoke about innovative policies in primary care, and the discussion was focused on what should give priority to prevention, the transsectorial across the participation, the territorial focus, and strengthening the networks. And we also spoke that there should be a policy led by healthcare from the governors and the mayors of the territories. And we had the fabulous experience of Caldas, where the primary care, actually we had primary social care, where we had bodies specific and norms that force all players and all the different ones there that we have there of primary care and so on, because we have intersectorial ones, and then we require and we actually postulated, we recommended the performance of the net to see what works, what doesn't, what we should follow, what are those key aspects in the APS network that enables us to establish their performance. Then we have to do it, and then we have among members of the same layers and the mechanisms there, so reference and counter-reference, horizontal there. And then we actually spoke about strengthening the work between professionals and specialists. And there's kind of a rupture, a break between these levels of care that actually end up duplicating efforts, costs, and it makes the system inefficient. So we actually had some interesting experiences of how in Bogota they managed to articulate all of this. And we spoke of the model that we have of the policy of integral care in the country enables wants to sit down between the different territorial players around goals, common goals, to establish the mechanisms, the routes that are actually in the norms of the policies for us to solve in an effective way the problems of health. Now, in matters of human talent in health, we spoke of having those incentives initially of the systems more towards the actions or that are salutogenic than actually curing, without forgetting to cure. Yes, of course, we need to cure and cure the illness, but if we actually turn our eye to prioritizing the sections of promoting health, we actually can impact in preventing illness and the professional deaths. We need more labor force in medicine, in nursing, in community managers, in family doctors, in personnel that actually take care of primary health care. And that's why we spoke of the need of reorienting actions, curriculums, contents, and practices to actually train properly the human talent in health as we require. And we spoke and we recommended these new schemes. We presented them with the experiences from Nariño, Tumaco, where one were able to organize adequate the teams, our own professionals, and these community managers that go to the territories, to the houses, and they enable one to solve problems in the domicile, in the community. They run tests to have diagnosis, to educate the community, and this is a matter to do so, as well as to position these profiles in the health sector and culturally as well in the community so that they can recognize their value. Now, coming close to the last section, we saw and talked about innovations to strengthen the resolution at the first level of care. And what was key? To have a clear, differentiated primary care that is sufficient, articulated between the different disciplines and the different stakeholders, that enable ones to have efficient strategic organization of the personnel and to provide support with information systems that are interoperable. They can give the raw materials for the monitoring of actions of the users, their conditions of health, of the health that they require, within the hospital and outside the hospital, and all the interventions done collectively as well. We also spoke of the need of how to have that health manager in the community, especially in the most remote, the most scattered communities where they have a high ethnic component, how they can help to solve, as we said in the plan, there are some situations like malaria, tuberculosis, in terms of diagnosis, the supervision of treatment, and they're very effective. And for this, we have international evidence. And here in Colombia, in the Nariño Hospital, they showed us, they showed us the network of the public network of Barranquilla, Mi Red. They showed us how the strategy of health walkers, they walk into everybody's house and places, and they go there and they resolve out in the field, out in the territory. So a combination between team organization and information system makes the difference in this end, according to the innovations implemented. And on matters of mental health, what did we hear? Well, there was a focus that is intersectorial focus, where we need to train and enable the health personnel, technicians in health, and health managers in the community, not specialized people, to diagnose in a timely basis mental illness. We have the tools of the MHGAP, the mental health assessment tool that actually they do in certain territories of the Pacific, and Médecins Sans Frontières showed us there how they do it in Nariño. We can improve the diagnosis and the timely intervention. Of course, establishing the channels of timely references of these specialized care when it is needed. And then they showed us there, as of academia and NGOs that work practices of reestablishing ties, emotional ties, and restoring the communities. They teach how to modulate their reactions and how they do it in respect of all these losses that we have here. Actually, to mobilize the ones that we have in the support group, so that they can have someone that they can actually have the mental health, and they can create these reference mechanisms that we have in the mental health. So here, this is an example, a key example is how we can do primary health care in providing their services and so on, and the interventions collectively and of the people there in a concept of APS, a broad APS code. Finally, we had this innovation of primary care of the elderly, and we had the policy the policy for the elderly, and we clearly saw how it was netly intersectorial. And then we had all the ones we had in and around the ones of do a healthy one, and then how to provide the services, how these elderly persons, they feel useful, functional, they contribute to society. And then we spoke of agriculture in order to promote the one of the senior citizens, and how they impact, and how you find in the territory through these community ones. There we have of the people, and then we have for the health services, and we documented how we did this for the ones for the cognitive wins, and then we have there, and then we have a focus there. We have interdisciplinarity, no specialized, with geriatric doctors that we have there, how they interact with the teams, you train them and so on. Then we see the experience of Canada, the multidisciplinary groups. They're actually led by these nurses that they offer the diagnosis there. And they create the channels to actually have access to tests, to have specialized services when they're required, without overlooking the infinite role that they have to have, importantly, those caregivers of the elderly. They came here, they were very beautiful there to develop this adaptive ones in the caregiver, because if we don't have a good caregiver that is optimum, then the quality is not going to be the same. So we're going to recommend, as we actually said there, to give the recommendation of development to encourage their well-being and to give them tools so they exercise their role in the role of caregiver. They actually start there without much competition. I think that there will be many more learnings that I could share with you that are shared through the media of Salud Derecho, and we can also be here to let you have these links that go with these summaries of the technical memoirs, some of them in Salud Derecho, that are going to enable you to have access to this key learnings that we have from here onwards. I would like to hand over the mic to Oscar, hoping that mine had context and it was useful for what we did. Thank you very much, Luis Gabriel. We want to give a special greeting to Dr. Gina Tambini, who is a representative of the PAHO, who is present at this event. As I mentioned at the beginning, we're going to have two panels, guest speakers. The first one where we will discuss in respect of the applications of the innovations in APS in Colombia, and the second that is going to take care of the same topic, but from the territorial perspective. Without further ado, I'm going to give the mic to Janet Bonilla from the World Bank team that we're going to model the first panel. So Janet, please. Thank you, Oscar. Thank you very much, and good afternoon to all. Without further ado, in this first panel, we're going to see the national perspective. We have three people that know very well the primary healthcare, to whom I appreciate and respect enormously, and who were part of the leading committee of PHPCI for Colombia during the first snapshot of our country that was actually published at the beginning of 2021. We now have the accompanied Teresa Tona, and the executive director for the Excellence in Health of the Javeriana University, with a master's in public health and a PhD of health systems, both of California University. Gabriel Carrasquilla, the president of the Medical Academy of Colombia, a doctor, a magister, and PhD of public health from Harvard, ex-secretary of health of the Cauca province, and the ex-director of FES and ex-director of the SEIS of the Santa Fe de Bogota Foundation. Also, we have here Dr. Augusto Galan, the director of the think tank of health, a doctor, a cardiologist, and a public administrator, former Ministry of Health, and who has broad experience in designing and implementing policies, public policies in health and in social security. Welcome. Well, whoever has questions, you can pose them in the chat. And we're going to have some sort of opening questions to use these 20 minutes of panel. The first question, you're going to have these opening questions, and each one of them, they have 3-4 minutes. I know that we can learn lots more, and I am embarrassed to tell you to be brief and do not extend yourself in them too much. So we can give opportunities to those there. We want to speak with you. What are the challenges and opportunities that we have to implement innovations in primary healthcare nationally? The orders, first Teresa, then Dr. Carrasquilla, and then Dr. Garay. We're going to continue with your answers. Please. Terry. Thank you very much for this invitation. I feel profoundly honored of speaking and addressing all of you and having been invited by all these dear colleagues from the World Bank. I feel very honored of participating with the panel with people of the experience and the track record of Dr. Galan and Dr. Carrasquillo, but with whom I also have the pleasure of having decades of working on these topics in such a way that this is an opportunity that brings joy. And the question that you're posing our colleagues, and that they have worked, all of you, so judiciously in the other prior webinars, leads me to a response that you already gave us. In the report of November of 2019, I think that's the Jeremy date, this clear for me now, the response. And that is, aside from what Manuela told us and what they did in their presentation, very exhaustive, given by Luis Gabriel, in this country, we know how to do many things well done. And we have examples that are very, very special. However, we bring them as examples. We don't bring them as the consistent reality throughout our system in our country. And that leads me to think, and how do we implement these successful experiences and make them streamlined? And I go to the point with which I was going to start of the report of the bank, the evaluation that we did of the quality of the APS in Colombia. And the response at that time was very clear. We need management, we need quality, we need management and quality. It means we need a whole series of institutions that if you need the managers implement some strategies that are fundamental of doing them right in the system of health, that you have them in the context that it be with the financing that there is. And of course, of all these things, we need far more. And what we describe in the webinars is absolutely fundamental. But we have examples that we can do it with just about no resources we can do it, but yes, it can be done, can be mediated by that gearing that we were speaking there, the conviction of the multidisciplinary team that there is a way of doing it better, and that is adopted within the organization, so that their community-based activities, be them the great hospitals or even the insurers, integrated, not integrated, public, private, ambulatory, and this is true for all of them. So are they willing to measure? Are you willing to standardize? And they do so continuously, pursuant to improving, because they have it all clear. And that is my second proposal for all this work that you carry out. And then we can give you here some important examples, like my network in Barranquilla, Dr. Mendoza, that I know well, where the program of walkers has had such an impact. I think that we also have to remember that in the system of health, be whatever we have in the conditions that we have there, etc., that we have, and then all of this has in mind the people, all of us, and then we're just a medium through the results, and everything that we do is this, and all our efforts, we're actually to give people the opportunity of what they want to do with their lives and improve their working conditions, but once again, we're just the medium, we're not the end goal. And then we have that all these actions that they have there that we work for ourselves. It draws my attention profoundly the phrase with which Luis Gabriel started in the introduction, and that is the fight against fragmentation. The primary care and health has in its axis from the very beginning so much work that we work, I don't know, 30 years ago, in between the axes, one of the pillars to be multisectoral and to be integral in the care that we provide. Integral care means that it means the non-fragmentation. And I am concerned, and I express it like that negatively, there's to take it into positive, that in the proposals that are being made, primary care in health would seem to be a pillar that is next to the other one, that is the service provision of the cure services. For me, that is my proposal in positive. And our country has shown that, yes, it can be done. We have plenty of examples. Mi Red is one of those, and I'm actually taking the presence of Dr. Mendes. I'm sure that there are many others. But yes, you can work in an integral way from primary care. Being primary care, the great guiding light, the integral care from the promotion of health up until the rehab, keeping in mind always the clarity that the center of everything are the patients. The pillars cannot be primary care or public health versus a curative system versus hospitals. It cannot be first level of ambulatory one before specialists. You have to work together. You have to integrate. You have to be intersectorial. The opportunity is in that we have it clear. That's our opportunity. The instruments, we have them in our country. And I like to close my comment with the great conclusion of the report that was presented by Jeremy in a forum in Cartagena. And that is, without quality care, care is dangerous, care is costly, and care is nothing more than a waste. So it's there, my invitation, therefore, that we think through in all of this. Let's not ignore any of this as the great exercise of improving the quality of care, of primary health care, so that we can do it throughout the entire health system. Thank you. Thank you very much. Thank you, Terry. Dr. Carrasquilla, you have the mic. Please proceed. Right, so good afternoon for all the people who participate in this webinar. A very special greeting to the entire team of the World Bank. As always, it is a pleasure to share with Teresa and with Augusto, and think that I could close by saying that I felt illuminated with the last part of the intervention by Terry, because there one justifies the 11 webinars that we had, that Luis Gabriel presented, where we had at the World Bank. And I just wanted to get to that, but Terry got to it. It's just that primary care, the strategy of primary care as was formulated long ago, and it's still current, and that was updated in Estana, and that the Estana update is exactly what Terry said, is that the strategy of primary care cannot be away from the health services. There cannot be, as she said, very figuratively speaking, Terry, on the one side, one pillar, and then the other pillar somewhere else. No, and that is the integrality that one must have in primary care. Answering a bit to the question that was posed by Janet Bonilla, we do have an opportunity here in Colombia, and that is that the primary care became an issue, since we have included it in the bill that is being presented, and there has made so many emphasis that it should be implemented, the primary care. Well, fortunately, it's become a topic where we are all opining in respect of primary care, speaking of primary healthcare, saying that primary care is important. Finally, since 1970, we finally in Colombia, we're actually doing, not even when the discussion of 1438 in 2011, that for me initially was not all that clear, but when I read it as a result of this entire program of the reform bill, I think that it does have that approach of strategy of first level of care, but not level of care, because we have to differentiate very well. One thing is the first level of care, and another is the strategy of primary health care, as it was formulated in the Alma Data and relaunched in Estana. But that doesn't mean that, yes, I have seen and I have said it openly in all the forums where I have been able to go in the reform, and I have always had the backup from Augusto when I speak about that point, and that is that one cannot have it disintegrate of what you speak of primary healthcare as decisive social ones, a multi-focus and community participation using the technology appropriate to the complexity of the problems that we have to solve, etc., with the integration of health services, as we already mentioned, and so on. But I think that we have that opportunity. And it seems to me that one of the opportunities, unfortunately, like everything, is very limited by the amount of space or the possible that it was to identify, is to have a recount of actions, programs, projects, activities, interventions in primary healthcare that were presented in these 11 webinars. And I think that it's well worth its while to continue to explore other experiences in respect of primary care as a strategy, because we have had an enormous learning, very important one. I just wish to highlight one of the three of the 11, because of the challenge, and now I'm speaking of the challenge that the primary healthcare strategy constitutes. The last two, which is that one of mental health and the elderly, and then of course it has the of chronic illnesses in other areas. If there we do have a duty there of the primary healthcare, is precisely that. That doesn't mean to say that infectious disease issues, the one that I had to coordinate with Chagas and HIV, that actually was presented, I had very beautiful experiences of using appropriate technology associated with the problems that one has to solve, like early diagnosis for malaria, etc., etc. They are also important. But what is coming now, because of matters of the epidemiological changes of mental health and COVID-19, of course, the long COVID, and then the elderly like me. I mean, more than Teresa and Augusto, much older me I am. I mean, and how the part of chronic diseases. There, one, you have a task that is very important, the primary healthcare, where one has to make that intersectorial focus work. And here we have a challenge that I've also expressed, that we have applied very much in many experiences in projects that we have pursued in different countries in Latin America. And I have insisted very much in these discussions of the reform to health. Primary care is not managed from the Ministry of Health. Primary care cannot be done from the 32nd Street. Primary care is done, as annotated by Luis Gabriel in one of his comments, territorially at the municipal level. The experiences that we have had, as I have said, from Mexico all the way to Brazil, in many of the countries of Latin America, of experiences of strategies of primary care focused on the municipality. The mayor is the one who is actually to get an intersectorial agreement, a committee, an intersectorial committee as being proposed, which is a council of ministers. The best way for it not to work, you have to give it operational, where decisions are made and where one designates the resources. You just don't even know the achievements that we had in Armenia or in Fortaleza in Brazil, when we did it municipally with the participation of the municipal authorities, focusing on the social decisive factors and the community participation to impact problems such as dengue. So for me, that is the main challenge. The main challenge is to know where one should locate the implementation of primary care. Janet, you're making some sign when I should be closing, because as you said, one gets encouraged here and you end up talking and talking and talking with all these things. So for a couple of minutes, another point that I think that is important, and I think it's also solved locally and was also mentioned, was the matter of financing of primary care. And that is also an important challenge in what we are living in Colombia. And Augusto is going to tell me if we're going to end up living it or not, which is the program of the reform bill in the discussion of the financing of primary care. And there we have to participate, or better yet, we have to have the community participation, the experiences. Tere remembers there in Cali, for example, in the neighborhoods close to Agua Blanca, as a clear community participation. But here, I want to make many of the experiences, not of the most recent presented in the webinars, but rather of the prior ones where we had a lot of opportunities to participate, and we use the primary care as the cheap health, and the cheap health including the health promoters that were voluntary. There's the ones of least resources in the communities had to ask voluntarily to bring the health to the people. That is a sort of ludicrous matter. We have to have true financing and support to human talent, to technology, obviously, and to infrastructure to be able to develop the primary care. I wish to close, because I know that I have already spent 1 minute and 38 seconds, Janet, but I mean, to call, as I've done so many times in many of the current forums, that the strategy of primary care is not the first level of care, but it cannot be isolated from the health services, and it has to be done integratedly and adequately. And God willing, if this project were to continue, that one begins to understand that and we can implement it that way. Thank you very much. Dr. Galan, right. So firstly, Janet, thank you very much to all of you for this invitation. It's always a pleasure to be with you. I had failed on many occasions, and I like to apologize, obviously, but I mean, thank you very much for this invitation. I hope not to be reiterative, and I'm going to make an effort, because Terry, as well as Gabriel, very knowledgeable people, they really know of what primary care is all about. They have already manifested it all too well. I would like in the next 5 minutes to propose 5 topics in response to the questions. On the one hand, firstly, to highlight and to greet this initiative. I think that we needed it. I think that we needed to recognize primary care, that we are performing it in Colombia, and recognizing that in urban areas as well as in rural areas, we have been doing primary care with different specificities and peculiarities and different possible focuses, but it is fundamental to understand all too well those experiences, upscale them, reproduce them, and to find a way of generalizing them. And there we have to be innovative, understanding, on the one hand, a very one that has been already mentioned, that primary care is a strategy and not a goal, that the goal of the system is focused, and it has to be focused on people, families, and communities. And that for that, primary care plays a very, very important role. So one says, okay, fine, this is a starting point, or a recognition that we have to greet, we have to congratulate. How could we progress? And here's where I wish to appeal more to my to my background as a public manager, how could we progress further in this one? And I think we have a central point here is that we must check the decentralization that we have in Colombia and the way in which we have established decentralization. I mean, Colombia has developed two aspects or two models of decentralization, one political administrative through the state institutions, the secretaries of health, municipalities, etc., that somehow they actually develop Article 42 of the Constitution and the issue associated with the right to health, which is consecrated in that article. And on the other hand, the decentralization, the functional decentralization through the right to social security consecrated in Article 48 of the Constitution. Those two decentralizations, we have not managed to dialogue on harmoniously. We have not managed to do that. And I think that the primary care, that strategy of primary care is the one that actually should help us so that in the territory, in a more territorial manner, those two decentralizations dialogue harmoniously, whether collectively as well as individually, and the ones of public health, if one wants to see it from that perspective. But at the end of the day, is actually to integrate those two articles of the Constitution, the 48 and the 49, in the territories. And we should do so, and we should review the decentralization that actually frames itself in a adequate implementation of the guarding dimensions of the health authority proposed by the World Health Organization, who have been incorporated in our management system of health in the reform that gave life or that rebirth in the Ministry of Health some 11 years ago, and then in the institutions of the state that actually have not come to the territories, those guiding lights. Thirdly, I would like to highlight that we speak of some decisive factors in health. We speak of social protection. We speak of development goals, sustainable developments. And at the end of the day, I consider that we're speaking about the same thing, the well-being and the quality of life of the population. And that has to do with the intersectorial factors of there, because at the end of the day, we have more than 17 commissions, intersectorial ones in the country, or perhaps many more, that it seems that then we're reproducing them in the intersectorial ones, the sectorial appetite to prevail. And I think that the example that was given and was already expressed by the province of Calda to have a view of primary care that is more social, more broad, and then we have the primary ones should not be, the way I see it, exclusive elements and be something of the health sector, but rather primary care as one visualized it in the province of Caldas, seen as something that is far more integral of all the sectors working for that well-being and that quality of life of the citizens. And there, the way I see it, the planning department has to recover a venue and a running from the perspective of planning. They should be the integrating party there of those intersectorial planners nationally, that of course they have to be translated in the territory, and they should be in the territory where one must execute them, but they should have that national view that is integrating, and their national planning should play a role that is actually to recover, it should recover the role, the planning role that actually has lost, or they have distracted them in more operational matters. So this issue of intersectorial nature. And fourthly, I think that we already mentioned, but I wish to emphasize the issue of human talents. We need a national policy of human policy in health. We have proposed that we have the norms, we have the law, we have a law that is sufficiently robust. And the point is to establish a policy of human talent that actually encompasses three aspects: the pertinence in the training. We're talking of primary care, but the training actually is oriented into other aspects. So we have to work furthermore in the pertinence of the training, and the relationship of the Ministry of Health and Ministry of Education should be more strategic, not just formal of some type of a checklist of that relationship, but something that is far more strategic. What is the human talent that is required? How do we require it? And how are we going to train it? And how are we going to distribute it within the territory? What are the incentives? That actually has to do also with the topics of labor conditions, that more than the salary is how do we establish life projects in the territories so that our professionals in health really do find the scenario to enjoy their profession, to make their family grow, and to have a life project in their territory. And there we have to decentralize and concentrate the educational processes in the territory. And lastly, the issue of financial resources that Gabriel already has mentioned, which part of what they said is actually part of the analysis that you, from this initiative, propose, that we have to understand very well today how much we're spending in primary care of health. What are we investing in primary health care from the financial standpoint, to know how much is still missing? Because one supposes that we can do far more, but that should go hand in hand with a clear definition of goals, a clear ones of objectives, and to determine the needs, and that way we'd have the time to implement it, and how many resources, not only financial, but human resources and physical resources that are needed. So I think that there, in those 5 elements, I would try to summarize. And I think that I exceeded my time. Janet, excuse me, but thank you very much. Right, so I'm going to propose one thing. I would like to have, we have very few minutes to close this panel, so I'd like to give the possibility to all 3 of you that if you could tell us one closing message, because we have a couple of questions, but I think that they have been answered from what you've said. So it'd be interesting for me if each one of you, I forgot to say this, I forgot to this, if you could give me a very short message to close this. Thank you very much to hear you all. It's always a pleasure. It is always enriching, and we always learn a lot. So thank you very much to accompany there. But one last message, Terry, I think you would go first. I think I just want to emphasize what I said. 1, it's all about integrating, defragmenting, and to think in primary care as the great continuum from the promotion to rehab. 2, we have to be absolutely focused on people, the family and the community, and that everything is geared towards, from the question is, what is it that people need? And be that what we try to build. And 3, I reiterate, as was already reported by the study, the assessment of the status of the sector is actually good management, good quality. And yes, we can. Thank you. Dr. Carrasquilla. Thank you, Janet. 2 messages. 1, I'm going to continue with what Tere said at the end, and that is that when we did the assessment of the PHCPH at the end of 2019, one of the weaknesses that we found in the primary healthcare is actually governance. And one of the recommendations that we did was the need to strengthen the local level to implement primary care. I think that that one is one recommendation that is still standing. And then the second one, I want to make a reference to financing, because when we are thinking in the scenario of the reforms, it is actually very complex, very difficult to think in how we're going to do a change of destination of resources of primary care and the first level of care to have more resources at that level, reducing, not reducing, but but almost competing with the resources of high complexity. That is a tremendous difficult decision, and it's actually very long term, because we have to do the promotion, prevention, early diagnosis at the first level, and intervene the decisive social factors, et cetera. And the effect of that is going to be seen in a generation, at least. So the ones who have to make the decisions to designate the resources, they need to know how to balance that decision and to think long term. Is not to take 30% here to high complexity for primary healthcare as of the 1st of July of 2024, but rather you have to do a process that is very planned, and keeping in mind that you need resources for both scenarios during some time, while that emphasis on prevention and promotion has an actual impact in improving the health conditions of the population. Dr. Galan, well, Janet, two messages then. First, let's believe in ourselves a bit more. Let's believe in what we have. Let's believe in what we have achieved. And let's understand that the path, we haven't finished it, we're just halfway. And then we must continue to progress, and there's plenty to do. And for that, that would be the second message. Let's learn to listen to one another, to realize that we do not have the truth revealed, that we don't have the last word, because no one really has it, and we have to learn from the experiences and of the knowledges of others and build collectively. And I think that for me, this which we're seeing of primary care, somehow, I would summarize this in those two aspects. Go ahead, Teddy. Go ahead, Teddy. That which you just said is actually fundamental. The problem of this dialogue of deaf people that we're country, and in many other countries, sadly, the problem is broad, and that is that we think that who doesn't think like us and doesn't act like us is actually ill-intended. And well, you judge, and then you come with the prejudice that the other one doesn't want to serve. I want to leave a premise as a basic message. I think I forgot, Janet, that I forgot to say that with very counted exceptions, those who choose the profession of health, those of us who come to work in this sector, we do so because we wish to serve. There are many ways to serve. It is possible that from many points of view, it can be radical different from what I have in front of me. But that does not mean to say that the intention of one are ill-intended and the other ones are noble intended. It's different from serving. This is a sector of services, and we all want to serve. So we have to listen to one another, because we all start from the common principle that what do I do for my fellow neighbor? Thank you, Janet, and excuse me for that. Thank you to all three of you, as always, very illustrative. I'd like to give the word there. We cannot continue to speak with you, but I'm going to give the mic to Oscar so that we can give the continuity to this session. Thank you. Thank you very much, truly. Thank you, Janet. In truth, I'd like to hand over the mic to Manuela, who's going to lead the next panel. Manuela, please. Thank you very much. Now we're going to pass to a different conversation, but from another standpoint, about the applications of innovations in primary care in health, territorially speaking. And we have had some food for thought that have been fabulous, really interesting, and thought-provoking of different ideas and recognition of many topics. So I am grateful for Gabriel, Augusto, Tere, and for those reflections. Really, I am very happy and I'm passionate about all of the things that you have mentioned. I wish that in this second panel, we explore with the secretaries of health, certain territories of Colombia, how to implement, as a matter of fact, in practice, the learnings and innovations in APS, keeping in mind that array of situations and factors that have been so heterogeneous that could facilitate or make difficult that intent of the provinces, districts, and municipalities of the country. With us, we have at this panel the Subsecretary of Territorial Management of Health in Bogota, Julian Orejuela Benavides. He is a former consultant of the National Council of Reincorporation of Teacher. He is an investigator. He's an odontologist of Javeriana University. And we also have with us Humberto Mendoza, the Secretary of Health of the city of Barranquilla, a doctor of the Libre University, a magister of the National University of Colombia, and a specialist in health management and social security, who has always worked as a director of the administrative department of Barranquilla and the subsecretary of health in the province of Atlántico. Thank you very much and welcome. I think that this is also going to be a discussion that is going to be very enriching. I wanted to start with a question that I hope also generates a lot of ideas and discussions for both. I mean, the first question is, if in your opinion, what are the main challenges to implement innovation in primary care, in health, territorially, pursuant to the capacity of responses in the needs not covered by the population? And I want to add also with the goal of really giving the necessary services in the different sectors focused on the person. So I would like to hear from you, if we could start with the Mendoza, Dr. Mendoza, and then to start with Julian Orejuela, and I'll be very grateful. Thank you very much, and please proceed. Right, Manuela, thank you very much. A greeting to all the members of the team of the bank who has been there with all the sessions of webinar. So greetings for Jeremy, and especially the ones that I've actually has seen closely the issue of Barranquilla. Dr. Teresa, that effectively has had the opportunity of knowing in detail the repertoire of what we've done in the district, and all who are here with us. I would believe that Dr. Augusto said something, and I think that that's the main opportunity, and it's to take advantage to speak about primary health care. There isn't no more favorable moment, no better opportunity than to have in the public agenda, that for us to have in the political, academic, and business sectors of the economy, a topic that actually impacts the entire population. Effectively, we, as a health sector, we really service the contingency of the social determinants that people have. I believe that in that first opportunity, if we actually become humble enough and we take advantage of the criteria of the analysis of health situation that each territory may make, and that it should have a priority according to his or her realities, we would be seeing that there are some conditions in terms of norms and some conditions at this time that favor exploiting the potential that the country has in and around effectively building at each territory a model of care, primary health care and health, that actually should be considered, that it is very different. The great urban centers, the medium-sized urban centers, and the smaller municipalities, less than 50,000 inhabitants, and a strategy, an activity, and an intervention, an individual one, so collective one, is going to be different in each one of these territories. But I believe that to be able to work today with the implementation of basic health themes, we are, since 2008, these walkers of health that today are going to pass to be work of the basic territorial teams. And we have some basic units that are called steps, these points of health, of timely health, between 10 and 12 walkers servicing between 200 and 400 families each. And truly, I think that if we do manage to have a minimum infrastructure necessary, sufficient with community ties, we can advance plenty. I think that it is evident that that liaison with the community between the housing and the basic health service provider has been lost. In many territories, we have lost them for many reasons that already we have dealt with, but actually take advantage that there is a push for that mechanism reborn. So there is a challenge to take advantage of these good insurers and to improve others so that we can, like in our case, all the municipalities of the countries have, like Barranquilla has, the 100% of the population of the subsidized regime hired, all in the hospital network, in this case, the Red IPS, and where you have all pregnant mothers of the subsidized regime, absolutely all of them have all the maternal path, they have it in the network of provided of my network that avoids the fracturing. And the fracturing is a threat, not only to timeliness of care, but actually the continuity of this, and ends up, of course, facilitating the effects of a resolving capability that is not timely, adequate, and doesn't give attention to the actual needs of primary care. Primary care that should not be seen aided. We have in those steps internal medicine, gynecology, and obstetrics. So we cannot put a citizen, that a person, that the Colombian who doesn't have many, but have to take a bus to actually have theirs an assessment by gynecology or internal medicine and pediatrics, among the others. We must have in those primary units those minimum care so that we can actually service adequately the risks of children, of early childhood, of pregnant mothers, and the elderly. So I think that there's plenty to do in these webinars. We have seen beautiful experiences in all the territories. So that means that there is a footprint, our own footprint, that we must try to back even further the basic skills, especially in the small territories, so that those skills, as was well said by the prior experts, are there. We can help us to have more management, because what we really have to do is more management in the territory so that we can achieve the goals in scenarios that are quite complex of social decisive factors. Right, good afternoon to all. Thank you for this invitation. From Bogota, I would like to share some thoughts in respect of the challenges and opportunities. The first is actually to overcome the fragmentation in the system, and the fragmentation as of the individual and the collective, but also the curative one and the preventive one. Here we have some huge challenges that in the logic that our system has had, that has been guided particularly by the curing. And then we have to say, and we should say without being embarrassed, but we have to ask how much resources do we have there in the municipalities, right? A typical case is Bogota, where someone has their own resources to be able to have a possibility to join the collective and the individual, as we're going to tell about. The second one is the care approach. There we have another approach that has been epistemological change from academia, from the communities, from the ones who are now practicing medicines. A few days I was listening that says that we in the health sector, we look more like lifesavers. So people, when they're drowning, they're very sick, then we save them. But seldom do we give them tools so they can navigate and then can go to the API. So there, I think that we're going to have a second challenge in the primary care. The third, as we mentioned, as Dr. Augusto Galan mentioned in the prior panel, the bet that we have in human talent, in training the human talent so that we can have learning tools and developing human talent territorially. So we have to continue there in that purpose of having sociologists, anthropologists, biologists that enables us to know our phenomena in the territory. And then we have there, we think that we have 20 Bogotas in places like Suba, like Kennedy, that are about 1 million people. It's kind of the population of Barranquilla and the population of half of Cali and so on. So there's a diversity of there. Only the air that you breathe is even different. So that training, that understanding of those phenomena also. The fourth aspect is the construction of state plans as opposed to government plans. Today we have a fear, for example, for destroying what we have had as an insurance model that has given results, but also we have had the same thing in Bogota. The prior government that we had actually eliminated all the territorial experience of public health for a matter that is criticized for ideological reasons, but actually that has happened before. So I think that there is an effort that is part of those structure plans that actually take care of the primary structure. Come what may, any type of government can use those tools that enable ones to bring one closer to the health services, to the communities. Another one is to have territories of the health actions. A fifth element that I wish to contribute is a bet of primary care that actually surpasses the epocentric approach that we have. If we don't take care of the planet, we're going to disappear. The health of the rivers, the trees, the animals is our health. I think that vision, we have to incorporate it within these logics. And I think that we, from the Secretary of Health, as a last element that we wanted to contribute in these challenges, actually to have open data, but also information system that enables us to actually work intelligent. For today, we have a debt is that the EPSs, the HMOs don't have the information of their citizens by the territories. So public health particularly sometimes work sort of blindly. We don't know where the ill people are, where are the people that have the greatest risk. However, we have been progressing that, but I think we have a debt, an information debt there. I think that we would mention like 6 aspects which are challenges and opportunities to continue to improve in primary healthcare. Thank you very much to both. I think that I'm hearing several topics that are worthwhile highlighting, that are very interesting. I wanted to take advantage of the fact that we have a little bit of time and to ask you a second question that really builds in the food for thought that you have just given us. We have spoken very much of the need to coordinate, multi-sectorial approach, and to keep in mind aspects and strategies that are several ones with the different players in the health sector and the primary health care. I would love to hear now from you, working territorially, how do you see, or what lessons of your work and your experiences would you share in how you, in reality, you can overcome this fragmentation between players in the territories to really make it very robust, the primary care in health. I know that Dr. Humberto Mendoza mentioned several of these topics, and Dr. Julián Orejuela as well, but I would love to see if you have any further thoughts or recommendations for other territories to how to overcome that fragmentation, or how do you get to a better coordination between players of the system, stakeholders of the system, to have a better care. Well, Manuela, effectively, I think that it is a structural problem. The fragmentation, not only in the lines of service provision, but rather in the way in which the stakeholders behave, the key players in the health sector. And if we do not manage for them to unify and kind of row all in the same direction, well, the forces dilute themselves and are lost. These are models of governance. It's important, the capability of being able to come together. I meet every Tuesday, every 15 days, with my 7 regional managers of the EPS between 2:30 and 4:30 of the afternoon. That scenario is really very important because it is a scenario of participative construction of the solutions that we may be able to have of problems that may be arising. That what actually, how they came there, that was an experience that we had from COVID. At COVID-19, we had daily meetings. We had now meetings with the shareholders or stockholders or managers of the 36 EPS of high complexity. That meeting actually contributes plenty. And that way we can begin to see the channels that are in person or virtual but permanent, and that they concentrate very much the explanation of how to tackle in an adequate manner, in a participative manner, in a uniform and homogeneous manner. We actually end up having and begin to change topics. At this time, we have the last 4 sessions every 15 days concentrated on the model of the operation of Padrino Hospital, which is the Abelita de Char Hospital of Mi IPS, that is a reference frame for all the public ones of the cities of high complexity for maternity. But necessarily that topic, the contractual ones of the agreement of wills and so with the EPSs and so on, there you have a topic there pending. And that has not been a limiting factor, and we have been able to progress in that. So I would believe that one has to put in someone else's shoes in the other sectors. Health is one of those one that has to put the shoes of education, of sports, of a Ministry of the Interior, Ministry of Government, and so on, and all the division there, so that what one says is that we have a shared value. Yeah, I can help you in education, and you have to help me as an education institution, as a dengue, so that we can work schools in a healthy way. So I think that we need that the health sector worked these strategies to generate some trust the way that we have actually generated. And that explains why today all insurance companies not only hire the subsidized system, but actually we had never seen before that whenever they hired the contributive regime, and I take a concrete example, all the EPSs, and I like to highlight in Salud Total and in new EPs, they actually hire the population of the contributive regime, but these are trust levels, and that trust level has been earned through the results in health and to share the financial risks in an adequate manner. Shared values, a lot of dialogue to put yourself in someone else's shoes in the different sectors, so that you don't go as a health authority there, and I'd rather to go there as a friend, a pleasant friend, and to try to find an agreement with objectives that generate value to the health of the people from Barranquilla, in my case, trust, and collaborative participation can actually help us to have the key so that we have less isolated pillars working, but actually working together as a group, because that actually more key, because they impact the social determinants, and that enables us to diminish the burden of illnesses that come to the provision of the health services. Manuela, allow me to talk about what we have been doing in Bogota with Salud to my neighborhood, Salud to my hamlet, to bulk leaders, actually to bring the health to the territories and territorialize the care. Bogota is not one city, but it's diverse, and thereby understanding that, we have proposed for Bogota and have built for Bogota with people 20 plans of local care, which is the political administrative vision. Yes, we have 20 localities. Those plans of care are built with the community and with the epidemiological profile that from the health secretariat we built, that there are many of that, as we actually have in Salud Data, which is an open database that I invite you to query. And we built 20 different plans, and they're coordinated with the local mayor's office. So we have somehow like 20 secretaries of health in the 20 cities that are within the city of Bogota. And then they have the actions. Then we have 4 types of interventions or actions. What are the others, which are the strategic lines of work? Care in the home, caring environments that we have there in the school and the home, assurance of services, and participating in public policies. Those 4 things, we put them together in the plans. What have we been doing there? Well, what has been this great achievement that we have had at home that I wanted to mention? And that is the PIC is actually going to improve with the home, and this care in the home. They have 350 teams of that have to do there for medicine, for nursing, and for psychology. And these are resolutive. They actually solve. This is different from the proposal of healthy territories of the district government of today. The president of the republic is not only we get to the house and characterize and we send to the opinions, but rather we solve. We actually solve particular of the people of Capital Salud, which is our public EPS. And we have improved our relationship with the EPSO. We passed from that government of 10 people that we sent over, 3 actually had their appointments, and now we're actually like 8 people. We effectively have their appointment there. And that allows us, Dr. Roberto says, the issue of the caring route or caring stops that we have so that we can do it in a timely fashion. And it's an experience today, and it's something there, not as a reform of health, but primary care, but actually to join the collective issue in the terms of bigs. But if someone actually there, that someone needs special attention, you could give them right away. Today's disconnect to book that can do it, because in the middle we put the teams in there. And then the other thing that we have to keep in mind is that those teams actually do the characterization, but they cannot do it for procedure. That procedure has to be paid by the EPS. Is actually paid by Capital Salud. Today, we're sitting there in Bogota with many of the EPSs, finding that agreement to pay per event. And that's where we have the issue of reform, and that the data be provided so that we can have care, promotional ones, to actually have the social, economic, cultural phenomena, that we have the ecosystemic ones as of each one of the territories. I wanted to share that. What experiences do we wish to mention also before going to those ones? The progress that we have had in infrastructure. More than 10 centers we have built, strengthened the infrastructure in the most vulnerable areas of Bogota. Actually, to tell Humberto already knows, because I know he studied here in the National University. The services in Bogota are concentrated in the mountains and in the north, very few in the south of the city. So we have been building many infrastructure in the south of the city that enables one to be able to have the people don't have to travel to have care, and to have very high quality hospitals. 4 learnings that we have had from Bogota And we want to mention the pandemic left. The first is that the public is irreplaceable. In the most difficult times, all private players, who the ones actually had the vaccination, the management of intensive care use, the ones who centralize the territorial areas to care, were the Secretary of Health led there and actually invited EPSs and IPSs, the institutions and the HMOs against. The second is to build on what you have. You can't do every 4 years to start afresh. You can't do that. People should be respected like that and seriousness for all these people who assume the responsibility of their. We have this spirit of reform that we should all have, all of the government, that they want to give a territorial character to the care and the importance of an open and participatory government. Nothing about people without the people. It's actually very important there. And it's not rhetoric. In the agenda is what you actually build a different society, not those of us who assume these government policies or bureaucratic positions, but rather it's that people in day in and day out, the work of the community is the one that sees the changes, that you save money, that they get less ill, that you can have better system, that you have less out-of-pocket expense. That's what the primary care, that's what the primary care is all about. And concretely, that's what the most vulnerable, the ones more harmed there's in society, you actually take care of their pockets. And that's a message that we wish to leave from Bogota, is what we're doing with Salud Amigo. Excellent. Thank you. Thank you very much to both of you. Really, there's some thoughts that are very, very useful, very inspiring. Thank you very much for sharing the experiences of Barranquilla and Bogota with more detail. And I think that the idea of this webinar was actually to consolidate that of knowledge, but we had even further, and we have now more experiences that are fabulous to be shared or from which we can learn. So really, I am very, very grateful. Now I'd like to pass on to Oscar so that he can actually guide us in the rest of the conversation. But once again, thank you. Thank you very much. And excellent, excellent, excellent food for thought. Thank you very much, Manuela. Now we're going to go to the international conference by David Vishai, who is a licensed in philosophy and physics of Harvard University, a master's in public health of California, Los Angeles, and a doctor of UCA in San Diego, and then a PhD of the Walton School of Pennsylvania University. Currently, he's the director of public health of the University of Hong Kong and attaché professor of the Bloomberg there of public health of Johns Hopkins University, where he was professor for 27 years. Also, he works as a health officer in the state of Maryland in 2021. Dr. Vishai is an outstanding economist of health, and his research is focused on the performance and the financing of the world activities of public health, private care, vaccinations, and the disparity in health. He is an author of 2 books and more than 260 publications, scientific ones, review, Paris, and he was the president of the International Association of Economics of Health. Professor Bishai will speak about the relevance of innovation in APAs in countries of medium and low income from the perspective of the primary healthcare. For us, it's an honor to have his participation. Dr. Bishai, the mic is all yours. Welcome, sir.
Thank you so much. It's great to be here, and it's great to be learning from this discussion. I also want to thank the translators. The English translation has been outstanding today, and I really have enjoyed the discussion. I took the liberty of reading through the past 12 reports of this webinar series, and I really hats off to the World Bank and to all the participants who put this series together. I'm very glad that we were able to have Luis Bernal's summary of this material, and I'm so glad it's in the public domain now, because it is what we need, which is a playbook. One of the things that's come up today quite clearly is synthesized so profoundly with just a few words, which was fight against fragmentation. So thank you for bringing that up, Dr. Terry. It really is the the three-word summary of what we're up against when we try to bring primary health care into our health systems. So I'm in Hong Kong this morning, and our big concern in Hong Kong is exactly this: primary health care. We have the advantage of the attention of the political leader. The chief executive of Hong Kong has given several speeches asking his health system to embrace primary health care. So this is a top-led initiative. Unfortunately, it is not a bottom-led initiative. There are maybe a few dozen health system reformers in the medical community that have embraced the task. So we have this gap between having the leadership, but yet not the followership from the medical community. And the people of Hong Kong don't know enough about what they're missing out on. Our health system is deeply fragmented by hyper-specialization. We have a wealth of cardiologists and rheumatologists and thoracic surgeons and nephrologists. These hyper-specialists are providing all the care. There is really very limited services by generalists. Doctors do not seem to see their patients repeatedly, so continuity of care is minimal. There's no mid-level providership for nurses and nurse practitioners here. So this wealth of having many, many doctors and hyper-specialization has led to fragmented care, where you go to one specialist for your problem number one, and problem number two, you go to another one, and there's this constant mess of having to drive all over town to get care. So we have, at least this community, like many around the world, is looking to this example of Colombia, and we're so glad that Colombia has written the playbook. So I'm going to put in the chat box a quote that I think summarizes my thinking today. It's a quote by Lilla Watson, who was addressing a United Nations meeting in Kenya about 20 years ago. And she said, if you are coming here to help me, you are wasting our time. But if you have come because your liberation is bound up with mine, then let us work together. Let me describe what I mean by liberation. And it comes from, I think, the root cause of the fragmentation. You know, we're in public health, we want to think of root causes. I believe that the root cause of fragmentation in healthcare is the ego of the healer, the ego of the doctor, who has come to the world out of love, out of service, out of a mission to help people. And yet the ego becomes too much, and they get focused on their own self and their own needs and their need to heal. That drives them to specialize and to do the best they can, to be the best rheumatologist or cardiologist or nephrologist. That ego has led them to say, come to me in my clinic. I won't go to you. I'm the one whose convenience matters the most, and my needs come first. That's human. I don't really criticize that, because we're all in that space. We're in our heads all day. So the force of the ego has led to the healing profession decide that curing is most important, and our needs as providers are most important. That is one thing that requires liberation. We need to liberate our doctors from their own egos. And obviously the liberation of people is obvious. They are the ones who are suffering. They have diseases that could have been prevented. They have mental health issues, social fragmentation. And again, they look to the leadership of their leaders, their governments, their primary health care providers to help them escape the conditions that cause disease. So back to Lilla Watson, there's obviously a need for mutual liberation. So now we look to Colombia and the playbook that Colombia is writing for the world. Hong Kong is watching, many countries around the North and the South. Coming from the USA, we need to read the Colombian playbook on how to do this. What I see happening in the comments of Humberto and Julian and Augusto and others is that what has happened in Colombia is that there were people who learned how to integrate, to build the connections, and to listen and to be humble. So there is a profession called the integrator. in Spanish, the integratora, sorry for my pronunciation, somebody who is working to join and connect to find the assets in the community across the multiple sectors. Now, I taught in a school of public health my whole life, and I know that we don't teach this well. We don't have a playbook like the one you just wrote in this webinar series, and now we do. But it's up to the schools of public health and to all of us to really train this profession of integrating and to honor it as a profession, because that's what we all need. So going forward, these integrators who we put into our system, they will be obviously at the central ministries and at our district health centers and at our middle level. We need to honor this profession and recognize it throughout our systems, and to honor the fight against fragmentation by equipping a new group of warriors who can do that. I want to close by a closing quote by Mahatma Gandhi, who I think summarizes where our heads are today. Gandhi says that sometimes in life we get stuck and we don't know what to do, and he offered a talisman. He says, when you're stuck and you don't know what to do, he says, when the self becomes too much, recall the face of the weakest man or woman you may have seen and ask if your action will be of use to them. And then your doubts and yourself will melt away. That is the impetus that we need for this new profession of integrating. The action of integrating our multiple sectors and our care providing across sectors is of service to the weakest and the most vulnerable. And if we get stuck and we don't know what to do, I think Mahatma Gandhi's advice will set us right. So I just want to close by thanking again the work that you've done, telling you that the world is watching and the world is grateful to what Colombia has done. And we wish you all the best, and we want to help as Colombia goes forward. So thank you very much for having me today.
Thank you, Dr. Ishai. Excellent, your presentation, succinct, brilliant. And I would like to give the mic to Pilar. So in closing, she actually refers to the current actions and the future actions that the World Bank may do, and how do they tie in with the learning of these practicing communities and these webinars. So Jeremy is a specialist in public health in the region of the Americas that speaks Spanish, and in the Caribbean, and the nutrition and population of the World Bank. Jeremy is an executive of the care in Canada and in France, and he has great experience in quality of the care of providing the service, and Jeremy of research and analysis of health. Jeremy is a PhD in public health, a researcher in the health service from Amsterdam University, and a master's in hospital management of the Advanced Studies of Public Health of France. Before I give you the mic, Jeremy, we want to mention that in the chat, we're going to place a link in order to assess or qualify or evaluate this seminar. Jeremy, the mic is all yours, sir. Welcome. Thank you very much, Oscar. It is a very long resume at this time of the day, so I hope no one was bored to death, and I want to thank you for your patience. I also want to thank for the entire team that has worked for this 11th seminar and all the founding work that we have had, that you have performed with all the PhD PI studies that actually have benefited the country in decision making, and to emphasize the importance of the investment in primary healthcare as a model, a founding model for the transition to a system that may find the needs of the population in terms of health that is aging, and with illness burden with chronic morbidity. So I think that the contribution of PHCPI it's key for the country, and I want to say thank you for the entire team for that. Also, what I wanted to share with you was all this work of mobilizing and adapting it locally of knowledge, the global knowledge, this could be translated also in very concrete, in specific actions. And perhaps I wish to explain a bit that the work that we have seen in primary health care by the end of 2019, that it actually be seen in a greater effort of the World Bank, not only in these efforts of setting up the knowledge and adapting it locally, but also in the financing efforts that we are putting at the disposition of governments. Well, I believe that what is important is to say that in all the investment efforts that we make with government, investments that are focused in a type of special loan, it's a result-based loan that Colombian governments use with the World Bank. And this means that in this context, it's very demanding government because they give the funds as the results come there, and the bank only reimburses the government when results are fulfilled nationally. Now we have a loan of $190 million, and we are preparing a new package of $360 million. So it's resources, all right, and it would be important to know that these investment loans have a focus on primary health care, very focused on that, but not any primary health care. It's actually primary health care focused on quality, effectiveness of the services, and an emphasis on the most vulnerable, the have-nots. And I think that this is the promise of a system based in primary health care. So it's actually to see how the system of health, how the sector can actually help to reduce the consequences of the inequities that are so profound that we see in Colombian society. We work on very important topics for the country: access for vulnerable peoples in the rural or remote areas, in these effective services, especially for chronic illnesses. We work on reducing maternal mortality, improving the detection and treatment of breast cancer, on infant mortality associated with acute malnutrition, and finally to the effective access for the migrant peoples. And I think that all these topics of these vulnerable types of peoples gives us the opportunity to build long-term pillars with APC as the groundwork to strengthen health services. From our perspective, we have 4 topics that we think are key in strengthening the system in the long term, with a ground base of APC, which is quality, because in the country, we do have universal coverage and we have very low out-of-pocket expense, but quality is nowhere there in a good chunk of the cases. So this is key to build trust in the system and to assure the efficacy in the expenditures of public funds to the resilience of the health system, and how we can include aspects of preparation and response to emergencies of public health within the primary health cares. I think that the APC can play there a fundamental role, and also the role of APC in the adaptation to climate change. I think that that one is also key. And a third topic would have to do with the financial sustainability of the health sector, with the demographics and mobility that we have in the country. We do not have sustainability if you don't have a high performance APC. And that's a key message you should keep in mind. And then there's another important long-term issue, is the economic integration and social integration of migrants into the country, and how that primary healthcare can help to have access to these effective services to these populations. So these are the commitments. We work in the long term. We work with the government. We are very determined, and we have received a lot of support from this government to really implement and finance the reforms that are going to ensure that the APC in the country can actually fulfill its promise of quality service with inclusion, with a focus on vulnerable peoples. Thank you. Thank you very much. Oscar, please. Jeremy, thank you. First, I want to say thank you for this presentation that is so clear, and to say thank you to all guest speakers. Thank you very much for taking out the time, for setting up a presentation, for sharing your know-how in all these series of webinars. I want to say there. Also, I want to say all the members who are here, all participants, and Salud Derecho, Manuel Avila, Luis Gabriel Bonilla, Mr. Jimenez, and I want to remind you that all material that we have generated out of this effort has been lodged in Salud Derecho's webpage, and you have a link to that. In the chat, you can query, and to just register there, you could do it. And I also wish to mention that the technical notes in Spanish and in English will also be published very soon in the webpage of the World Bank. It was a pleasure to share with all of you, and may you have a happy day, morning, or evening, depending on when you are in the world. Thank you very much. Have a good day.